Okay, thank you everyone for joining us today. It looks like it's top of the hour. Just a couple quick things before we get started. Your certificates will be available this Friday by logging into your account. And feel free to submit any questions via the question panel during the webinar. We'll try to get to those at the end. Dr. Spatz, if you're ready, go right ahead.
Great, thank you. I just have to close out this and share my other PowerPoint. So here we go. So thanks for joining today. I understand we had quite a big registration. I'm very excited to talk today about helping all families make informed feeding choices. I share a joint appointment between the University of Pennsylvania School of Nursing and the Children's Hospital of Philadelphia. I also am on the executive board as treasurer for the International Society for Research in Human Milk and Lactation. In terms of disclosure, Medela is providing funding for this webinar that you're listening to today. I also, as I mentioned, am active in ISHMAL. I'm on the editorial board of American Journal of Maternal Child Nursing, and I continue to be the final approver of donors for the Child Mother's Milk Bank, which is part of HIMBANA. All of this presentation I am giving today is independent of any of those listed above. So today we're going to talk about the new WHO and UNICEF report, talk about why human milk is superior to both donor milk and formula, and then articulate scientific evidence with families. Now, I would be really, really curious to hear from people how many people even heard about the WHO and UNICEF report, because it has gotten really no media attention today or in the news in the US. Now, I want to include and start with the decision tree from WHO because we are still living through the COVID pandemic. And I think it's really important to always set in context that from the beginning of the pandemic, the World Health Organization has always supported early exclusive breastfeeding and skin-to-skin contact. Early exclusive breastfeeding and skin-to-skin contact, irregardless of COVID status. This is still an issue today because there are still hospitals in both the US and globally who are separating parents from their babies or babies from their parents with a COVID diagnosis, okay? But the WHO has always said we should have babies being directly breastfed. If they're unable to breastfeed, to express milk. If that's not possible, donor milk from a human milk bank. And lastly, they also include wet nursing or informal milk sharing if it's culturally acceptable and a safe wet nurse can be identified. This is very different than the US perspective, where the FDA says we should not engage in informal milk sharing in the US. So let's talk about the skin-to-skin contact, right? We know skin-to-skin contact is one of the most important things we can do to facilitate early exclusive breastfeeding and direct breastfeeding at the breast. But in the US, we have had hospitals either discourage or prohibit skin-to-skin contact, and that's to the tune of 1 in 5 hospitals. This is concerning and continues to be concerning because this is happening not only in the US, but also globally. We know that there has been a negative impact of the pandemic on birth and breastfeeding, and we have seen marked differences based on where people live, access to resources, and being able to find in-person breastfeeding help and support. So the situation for breastfeeding, right, even before the pandemic was concerning, right? We know from World Health Organization that we're still at less than 40% of babies getting exclusive human milk for the first 6 months. And we have seen decreases in both initiation and continuation rates in many segments of the population since the pandemic. And I'll give an example right here in Philadelphia at our largest outpatient primary care center, which serves primarily low-income African-American families. Breastfeeding rates dramatically dropped because of the pandemic. So this is really quite concerning because we already were having challenges with breastfeeding, and then the pandemic has made it worse. So this is the new report that I was mentioning earlier. It came out the last week of February. Now, what I find really fascinating about this is that the WHO and UNICEF really did quite a large media splash about the report. My dean of our School of Nursing actually heard about it, but yet in the public media in the US, this has not been talked about at all. And I find that fascinating given all the press that there has been related to formula recalls and formula shortages, which have made USA Today, okay? So people are talking in the general media about formula shortage and formula recalls, but no one is talking about this very significant report about the formula industry. So this report was generated from research done in 8 countries, Bangladesh, China, Mexico, Morocco, Nigeria, South Africa, the UK of Great Britain, and North Ireland, and Vietnam. Those countries were chosen because they represent lower income countries, higher income countries, and they also represent different countries in terms of breastfeeding rates, as well as if their country kind of looks at that role of formula marketing. So if we think about human milk and breastfeeding, right? Babies die, children die because of a lack of human milk. People don't like to talk about that, because you could be formula fed and turn out okay, right? I'm living proof of that. I was not breastfed. So sometimes people get uncomfortable talking about the fact that babies really do die from a lack of exposure to human milk. The report further goes on to talk about the fact that the formula industry has provided false, manipulated, and incomplete scientific evidence that convinces parents to use their product when not medically indicated, okay? And we now have seen marketing claims, right, that really make formula sound really great, like designed to reduce spit up or NeuroPro, okay? And formula companies advertise their product as a modern approach for busy families, and they play on the insecurities of parents about milk supply. You all know the #1 concern of parents all over the world is, how do I know I have enough milk or I don't have enough milk? Now, what's really, really, I think, significant and concerning that it has not been talked about or picked up in the general media is that the marketing still represents one of the most underappreciated risks to infant and young children's health. And so if you look at breastfeeding rates, okay, here in the US, we have had only modest increase in breastfeeding rates with initiation, right? Thinking about over a course of 20 years, going from about maybe 70-some% to about 84% now, okay? So very modest increases in breastfeeding rates. And if you look at exclusivity and duration, the same thing. However, in that same time period, formula sales have over doubled, okay? So that's really important to consider, because even though many people may be starting breastfeeding, they're not continuing, and formula sales are going up and up and up. So One of the major takeaways from this report, again, this is a study in 8 countries, WHO and UNICEF say the marketing of infant formula is no different than the marketing of other unhealthy products, such as tobacco, alcohol, and ultra-processed foods. And if you think about that, right, we pay in many states or many countries sin taxes on products like tobacco and alcohol and ultra-processed foods. In addition, they also compared it to the marketing of gambling. So there were several major findings from this study that was conducted, okay? The first was that the marketing channels and tactics are pervasive and invasive. And so they specifically target younger, newly pregnant people, okay? And they also utilize data-driven algorithms that target the digital advertising to people whose online behavior suggests they may be pregnant. The second major finding was that the messages are slick and misleading, okay? And if you look at this, which comes right from the report, okay, here we have Western advertisements, okay, where they talk about in China, Vietnam, marketing language such as Dutch quality and Swiss purity, okay? And they show westernized homes or households. They also play on people's emotional and aspirational pain points. So advertisements that focus on intellectual development and how products can help aid brain development and how they'll help infants and young children to grow. They also use the male figure, okay, and they advertise emphasizing the point of the male person to be able to participate in infant feeding, promoting a modern lifestyle. And then they also give misleading messaging and misleading language that makes families believe that their product is superior or better than human milk. And I think this quote from WHO and UNICEF is that they assume a friendly and supportive role to pregnant women while exploiting their vulnerabilities, right? And we know that families are very worried about their ability to effectively feed their babies. Finding 3, health professionals, okay? This was really amazing. And if you read the full report, they did over 300 interviews. And it was shocking to see the fact that health professionals really reported that human milk was inadequate, that health professionals thought that formula was necessary in the birth hospital stay, and that human milk alone was not enough. And especially when you talked about breastfeeding beyond 6 months, there was concern of the inadequacy of human milk. And in the report, they also found that many medical institutes were involved with advancing the credibility and claims of formula products. When I was working in India in 2016, I recall that when I was doing human milk and breastfeeding education in Jaipur, the education room was called the Nestle Library, right? So we know that this is happening all across the globe. The fourth finding was about women's experiences and voices. And you can see here quotes from many different countries where they really make the mothers believe that human milk is not enough, that it's not as good as formula, that the baby will sleep more if he's formula fed and not breastfed. And these marking strategies go through many different channels, including health professional recommendations. And it does influence women's attitudes. And if you look at the mother from Bangladesh, you know, she says the ad about brain development, that's why they want to buy the product, because everyone wants to have a smarter baby. Finding 5, opportunities for action. And here you can see a quote from the former Prime Minister of New Zealand, right? For decades, the formula milk industry has disregarded international recommendations when marketing, often to women who can ill afford it, okay? One of the things that I think is most significant from the report is that it's really not just the job of us who care about families and babies, but it's everyone's job to promote and protect human milk and breastfeeding, every sector of society. So I have a new article that will be coming out that really kind of discusses this report done by WHO and UNICEF. And there are 6 things I address in that article, but I really want to kind of just emphasize the 3 that I have italicized and bolded, okay? So the first, our society needs to recognize and expose the invasive and pervasive nature of formula marketing. And when I say our society, I mean everyone. I mean people who have no skin in their game related to pregnant people and babies. The third one, training and building of health professionals so that they can provide evidence-based lactation care. This is huge, and we know from the report and much other published literature that there is really a lack of health professional knowledge. And then the 6th bullet point, coalitions must be expanded to drive action across all parts of society. And really, I think that is critical, right? Because sometimes when we're together talking about lactation, we are simply preaching to the choir. We are talking to people who also think lactation is important. But how do we impact the rest of society to understand that this is an issue? So the US was not included as part of that WHO and UNICEF study, but let's think about the US perspective. In the US, 53% of our families are enrolled in the WIC program. And WIC does spend significantly more money on formula than peer counselors. And this is all public knowledge. Any of you can look this up and see this on national websites, okay? And we always see that threat to the breastfeeding part of the equation, not the formula part of the equation. And I would be curious in your area what the pandemic has done to peer counselor availability. Because what we're seeing in many segments of the US is that there is no live in-person peer-to-peer support. And we know that peer-to-peer support is a proven research strategy, right, to improve breastfeeding outcomes. In the US, 4 million people give birth. Over 80% want to initiate breastfeeding. So we're talking about 3.2 million families. And we know of those families, milk supply is the biggest concern. And that's not just here in the US, but that's also globally. So we really have to think about what needs to be done to help our families have better lactation journeys and better outcomes. So can you say that in your practice, every single parent is getting adequate prenatal education? Well, I would argue that we can't say that, okay? Because if we look at breastfeeding rates, our rates should be higher than where they are, right? because there's very few contraindications to breastfeeding. HIV, HTLV 1 and 2, active illegal drug use, okay, very few, which means that 95, 96, 97% of our population should be breastfeeding if they were all making informed choices. And we know that the health disparities have existed and continue to exist and really are not getting better across income levels, against racial and ethnic groups, and then also the impact of the WIC program. And this should be concerning to all of us because in our Black and brown baby population, we have higher rates of death and of morbidity. In the US in particular, structural racism has also impacted breastfeeding. So hospitals that serve primarily low-income people often are less likely to have donor milk available, and they also don't provide lactation support and care. So if you end up being a baby in that NICU and your parent hasn't made an informed feeding choice and you don't have access to donor milk, that means you're going to be more likely to die or to have NET or to have sepsis. So we have to acknowledge and address these disparities, because when we don't breastfeed, there is an intergenerational impact. And I will use myself because, as I told you, I was not breastfed. And because I was not breastfed, as an adult, I have to worry about things like hypertension, diabetes, obesity, okay? And I do worry about all those things, and I have to work really hard to counteract those things. And those impacts on my health as an adult, diabetes, obesity, hypertension, heart disease, they're also going to impact my pregnancy outcome. And I'm going to be more at risk for having a poor pregnancy outcome. And then if I have a girl baby, then my girl baby might end up being born prematurely. And then I might have a hard time establishing a milk supply because many of those factors like obesity and diabetes impact coming to volume. So now my girl baby ends up not getting human milk for very long, even though I tried. And then she becomes less healthy. And that cycle goes on and on. And, we just finished, looking at the week where we were addressing perinatal mortality. And we have terrible perinatal mortality in the US, okay? And so we have to really think about the important role of human milk and breastfeeding. And so when you think about mitigating against toxic stress, okay, we have many buffering effects of breastfeeding. So the socioeconomic benefit, you don't have to pay anything to provide human milk. The tremendous benefits of early skin-to-skin contact, and we know skin-to-skin contact isn't just about breastfeeding, and we know that skin-to-skin contact isn't just about early development, it's also about development into adulthood. And then we have to think about the milk itself, and that the milk impacts every single organ of that child. So how do we help families make informed feeding choices? Many of you have been on some of my webinars before, and you are aware of my 10-step model and my breastfeeding resource model. Baby Friendly Hospital Initiative is great, and it has done a lot of great things for care. But I also think that we may need to go beyond just baby friendly. And this model was developed for sick kids. However, what we found, especially in light of the pandemic, that this is important for all families. And I'm going to tell you why. Because if you don't help families make informed feeding decisions, and you don't help them effectively establish and maintain milk supply, you're never going to have long-term breastfeeding families. And so let's talk about informed decision, because I have this conversation so many times with so many people, and people are uncomfortable often talking about families making an informed feeding decision because they don't want to make a family feel guilty for not breastfeeding. They don't want to influence their personal choice or their personal beliefs. But when we think about, right, smoking, most people have no problems telling people they shouldn't smoke, that's bad for their health, or they shouldn't drink, that's bad for their health, or they shouldn't drink that sugar soda because it's bad for their health, okay? So we want to help families learn about why human milk is so important. Because remember, many families don't have family support. They don't have the cultural context. They maybe haven't had education or exposure. And remember, right, if you look at that WH report that says that $55 billion industry systematically undermines parents' infant feeding decisions and compromises the health of the family, okay? So families are systematically being marketed to choose formula. So if that's occurring, what is your role as a provider in helping all families truly make informed choices, right? So is it truly a personal lifestyle choice, or is it helping families make informed decisions? Every single family, okay, no matter what their skin color, their income, where they live, every single family deserves to have information about the science of human milk. And I would argue that human milk and breastfeeding should be addressed at every single time point in the prenatal period. Now, one of my students said she's working in labor and delivery right now. She just graduated in December. And she says she feels uncomfortable asking a family when they come in for birth, if they already say that they wanted to formula feed, she felt uncomfortable with asking them about breastfeeding. And I said to her, well, why don't you ask them how they came to that decision? And she said, well, if someone chose breastfeeding, I might not ask them that. Well, I said, well, then ask every family how they came to their feeding decision, okay? Because people often have a label on their box, right? Because it got filled out during the first prenatal visit. They're barely pregnant, and someone said to them, how are you going to feed your baby? And we check a box that says breast or formula, right? And maybe someone says breastfeeding is good, you should do it, right? But every single person we meet, the minute we meet them in prenatal care or at time of birth, is tell me how you made your feeding decision. Tell me what you've heard about human milk and breastfeeding, okay? And then my very next thing is you have to hear what their concerns, because people have concerns about breastfeeding. They worry they're not going to make milk. They're worried about pain. They're worried about going back to work, okay? They have all types of worries, okay? And if we don't first address their worries or their concerns, they're not going to hear anything else we have to say. And I think everyone wants to just give every single family the same 3-minute spiel about breastfeeding. It's good, you should do it. Check a box and we're done, okay? But we have to listen to people's concerns. And then we need to teach them about the science of milk and how cool it is. And then we want to ask them, how can I help you make human milk and breastfeeding work for your family and your lifestyle? Help them see that this is a good choice for them. You also see reported in the literature the time barrier, right? This is why we can't do better. When we are providing pregnancy care, there's limited time. We don't have time to talk about breastfeeding. We can only talk about preeclampsia, that's more important, or we can only talk about premature labor, that's more important, right? But that leads to the fact that breastfeeding education gets outsourced. And in some cases, people have to pay for that education, which means we then have more disparity, right? Because we have the people who can afford to pay and the people who can't afford to pay. So what are some of the solutions? Well, you can have 1-minute milk facts. You know, I always tell people I can talk about breastfeeding in 5 minutes, or I can talk about it for 5 weeks, whatever you want. So 1-minute milk facts. just add 1 minute of how cool human milk is to each of your prenatal cares. That means that people are going to get targeted through their whole pregnancy. Think about creative visual displays, right, everywhere that just show breastfeeding. And these pictures here are from Thailand. I have been working in Thailand since 2013. This is at their children's hospital, and these are the elevator doors. So every single person who walks into Queensbury National Institute of Child Health, okay, every single person who walks into that hospital is seeing the 10 steps for human milk and breastfeeding in the Spatz model. They are seeing informed decision-making and about how amazing human milk is for a baby. And here they're seeing human milk management and human storage, okay? So imagine having that prenatal space or that labor and delivery space or that postpartum space filled with creative visual displays about human milk and breastfeeding. I would also argue that establishing a nutrition or lactation consultation program during the antenatal period is important. This is something that has been a standard of care at my institution, because during that period of time, you can identify potential lactation risks that could impact coming to volume. You can understand their history and their knowledge of lactation and their family's history and knowledge, and also the expectation for birth. It also gives you the opportunity to involve the family. No one should be on their lactation journey by themselves. We need to involve the family in the care. We want to focus on the science, and I like to do this from a head to toe type of visualization, helping them understand that human milk impacts every single organ and every single system of the body. We also want them to understand that human milk and breastfeeding are dose dependent, and that some human milk is good, but longer and more exclusive human milk has even better outcomes. And one of the main things I like to focus on is the brain, because as soon as people have babies, they start thinking about where their kid is going to go to school, where they're going to go to college, how are they going to afford to have college, and everyone is worried about their child's future. And so we can think about how important human milk is to protect and develop the brain. So I don't know if any of you have seen this relatively new article from 2020 that looked at intraventricular hemorrhage, okay, and also periventricular leukomalacia. And it really does demonstrate that power of human milk in protecting the infant's brain. So human milk is brain power and brain protection. Now remember, formula companies are marketing their product to be neuroprotective. But what we know is the ultimate neuroprotection is human milk. So right here in this picture, we have Dr. Alan Lucas, who is, one of the famous first researchers in this field, where he randomized kids to get either human milk or pasteurized milk or formula, and he's been able to follow them into adulthood. And in adulthood, how you're fed as a baby impacts your brain, your IQ, your brain size, and your white matter. And then we have Dr. Sean Dione from the US, where it's no longer considered ethical to randomize people to breastfeed or not, but he's found that same type of impact. And if you look here, you can look at the groups of infants that were breastfed versus formula fed, breastfed versus combination fed, and there is a significant improvement on intelligence and developmental outcomes for those children who are human milk fed. He also looked into both short and long breastfeeding duration, okay? And here, short is defined as 220 days plus or minus 81, and long is defined as 600 days plus or minus 124. So I'm sure some of you have heard people been told, oh, there's no benefit to breastfeeding beyond a year. If you think about Dr. Dione's work, he would probably argue that yes, there is in terms of the brain power. Dr. Dione has also looked at just the first 90 days of human milk. So imagine you have a family who says to you, you know, breastfeeding is not for me. I know that I'm going to have to go back to work. I know my employer is not going to be supportive of me taking break time, so I'm not going to be able to breastfeed when I go back to work, okay? So why bother? Why does it matter? Well, if you look at this research by Dr. Dione, you can see that just 90 days of human milk matter, right? So even if someone could not do it long term, it would still have a positive impact on the infant's brain development. So that brings us to this idea of parsing out human milk versus donor milk versus formula. And so when we think about this topic area, you know, we have to redefine how we think about and teach about human milk. And so remember, I told you I was formula fed. I turned out okay. So formula gives us nutrition, right? But human milk is not just nutrition, it's also developmental and immunobiological. Human milk is powerful, right? I still always have loved the Petri dish picture because it shows you how powerful it is for human milk to destroy pathogens. And if we look at just some of the key ingredients, when we think about antibodies, right? This is research by Dr. Rebecca Powell with the COVID pandemic, robust antibody response, okay? But here's what we also have to talk about, because when we're talking about human milk is the most robust when it is fresh. So if you freeze milk, okay, we have to decrease antibiotic activity. And if we pasteurize milk, we have decreased Ig activity, okay? So parent-owned milk is going to be the gold standard. Antioxidants, okay? And this was a really great recent article in 2021 about how storing human milk reduces the antioxidant capacity, okay? And so, unfortunately, if we're freezing milk, we're going to lose that antioxidant. And so that is important because that may explain some of the differences in outcomes that you see across preterm infants who are fed human milk. We know that human milk diets reduce BPD, ROP, and NEC, but we also see conflicting findings. Well, if a baby's only getting pasteurized milk, which has been both frozen and heat treated, he's not getting the same benefit as a fresh milk diet, right? If he's getting parent's own milk, but it's only ever been frozen, he's not getting the same benefit. Our human milk oligosaccharides, everyone I'm sure knows Lars Bode and his work, right? These oligosaccharides are tailored, they're specific to individual diets, they're prebiotic, they're antimicrobial, they're probiotic, they resist digestion. Now, the one thing good about HMOs, they appear not to be impacted by pasteurization, okay? So that's something good in the milk that does get maintained. But remember, not everything is going to be sustained with pasteurization or with freezing. Lactoferrin, okay, is another important multi-purpose protein. Bo Lauderdale has been, you know, paid by formula industry to try to recreate artificial lactoferrin. It's something being added to infant formulas, but it's going to be the best benefit for the child when it is from parent's own milk and when it is fresh. Because once we freeze human milk or once we heat treat human milk, we're going to reduce the potency of lactoferrin. So you're not going to say it have the same effect. Osteopatin is also another very important protein in human milk. That is important for the GI system, for the brain, okay? And again, this is another one of these components that is being artificially created to add to formula. But the most robust response that the baby is going to get of the OPN is through parents' own milk. And then our stem cells, right? And again, these are also going to be destroyed. So fresh human milk matters. The parents' own human milk matters. So just a reminder about the teaching tool we have, that is the power of pumping. This is something that we can make available to anyone who is interested. It's a 20-minute video that goes through the science of human milk. So when we think about pasteurized donor human milk specifically, it wasn't until 2012, so just 10 years ago, a decade ago, where the American Academy of Pediatrics came out with a statement about PDHM appropriately fortified for preterm infants, less than 1,500 grams. And it wasn't until 5 years ago, a mere 5 years ago, where the AAP had a separate position statement on donor milk. And their major focus in that 2017 position statement is about the nonprofit or Himbana milk banks. The AAP says that donor milk should not be a replacement to mom's own milk. It should never be viewed as a replacement, but as a bridge. And they discuss the priority of donor milk being for very low birth weight infants, but acknowledge that it may be important in other populations. They further state that there are no clear indications of when to wean, which means you see all different types of different practices in clinical practice. They also say money shouldn't be a barrier, but we know that only about 50% of NICUs actually have donor milk available in the US. They also talk about informally sharing milk and the difference between commerce-driven versus commerce-free. And they state very clearly not to buy milk on the internet. But we do know some families will still choose to informally share. And I could do a whole nother talk on that topic. So at Children's Hospital of Philadelphia, I think we have one of the broadest donor milk policies that I've ever seen anywhere I've been in the world. Because we include not only prematurity, but also post-op nutrition, immune deficiencies, certain inborn errors of metabolism. But I think what's really key is number 8, which is parental preference, okay? So when we think about when should we be using PDHM, okay, there is some research from the US, Canada, and Europe that actually says that PDHM maybe doesn't really make a big difference if when compared to formula, okay, in both short and long-term outcomes. However, what's really important to remember is that in those research studies from US, Canada, and Europe, the babies were getting a high dose of their parents' own milk, okay? So if there's a high dose of human milk from the lactating parent, that's what's gonna keep the baby the safest, okay? Now, some people will argue because of these studies where it showed that supplementing with PDHM doesn't make a difference, you know, people say, oh, well, it's okay, we don't need donor milk. We can just get formula, right? But we also know that there is data that shows that when we have donor milk available, human milk or parents' own milk rates go up, and NEC also is decreased, okay? So it is worth it to invest in donor milk if you have that messaging be correct, in that your milk is so important that if you don't happen to have enough of your own milk, we have this bridge available to support your baby, right? So it's not saying that donor milk should be in place of parents' own milk. It's that donor milk should be there as a bridge to parents' own milk. And when we think about this from a cost perspective, because cost is always something I hear of as a barrier to donor milk. If we were only using small amounts of donor milk for trophic feeds or supplementation, the dollar figure on that is quite low compared to other things we spend our healthcare dollars on. So in 2018, I was guest editor for Joggin, and I won't talk anything about that whole series other than the cost-effective nature of donor milk. And so this was 281 infants, and this was at a time before we were our own milk bank. And we found that the amount of donor milk needed on average was 195 mLs with an average cost of about $29. So if we think about total parental nutrition is over $1,000 a bag. So 44 times more expensive. So when we use donor milk appropriately as a bridge, not a replacement, that's when we're going to see the best clinical outcomes. Now, I do want to just acknowledge and address that not all donor milk is equal. My co-author in this publication is one of my former students from Penn, and she is a new assistant professor at the University of South Florida. So where we have the largest body of evidence for the benefits of pasteurized milk is on the pasteurization method. So either that pasteurization, which is being done by Prolacta, or the Holder pasteurization, which is being done by both Himbana and the European milk banks. We've had companies that have developed retort processing. And retort processing involves sterilization of the milk. It makes the milk, quote, shelf stable so it can sit in room temperature for up to 3 years. And that method destroys the bioactive protective components of human milk. Companies who sell these products do aggressively target hospitals to purchase their product. And this article actually came from a hospital in my home state of Pennsylvania. And the hospital was approached, they changed their milk to a retorted milk, and the nurses really were not happy because there wasn't evidence, but they didn't feel that they could do anything but go along with it. So Medicate is one of those companies that makes retorted milk, and they have filed for bankruptcy, so it will be interesting to see what occurs. And then we also have Nicu, who's another company who does make the retorted milk. Now, what's interesting is that that company is marketing directly to parents, and they have information on their website. But if you think about the cost of purchasing such milk, it would be cost prohibitive to feed a baby milk like this for any amount of time. So some of our Himbana milk banks actually offer options for parents to use donor milk as a bridge. So Mother's Milk Bank of North Texas has donor milk to go. And so parents, if they're well informed and don't want their infant to be supplemented, could buy milk and bring it in. But do all hospitals support this practice and allow for that? I've heard many people who've had challenges with bringing in either their own antenatally expressed milk or milk that they purchased from a milk bank for supplementation. So when we look at the bioactive components, okay, for these components, remember I talked to you about the fact that many of them are diminished with freezing, and then they are also further diminished with pasteurization. So that pasteurization does result in more or better levels of the bioactive components compared to the retort sterilization. And so again, thinking about where we have the evidence, the strongest evidence for human milk is fresh human milk from the parent directly, okay? Once we freeze the milk, it becomes degraded. Once we pasteurize it, it further diminishes components. But with the retort milk, really, many significant components are significantly reduced. So, what is the takeaway message for you all? Okay. I think donor milk is very important. I went through the process for Children's Hospital of Philadelphia to become their own milk bank, okay, so that we had donor milk as a bridge to parents' own milk. But there's no research to support that donor milk is better than parents' own milk. And it's become very sexy to build a milk bank. And I was part of a World Health Organization task force concerned about the growing interest of milk banking globally. And if we think about building milk banks, right, staffing milk banks and making donor milk, they're really expensive undertakings. You know, we bought our pasteurizer back in 2014. It cost $75,000, okay? Think about how much lactation support you could provide with that amount of money. There was a really interesting quality improvement study published that came out of Spain, and they looked at putting a breast pump at every bedside. They looked at their human milk rates before that practice, and they looked at their donor milk rates before that practice change. And after they put a bedside pump at every bedside in their NICU, their human milk rates at discharge significantly increased, and their use of donor milk decreased significantly, okay? So we need to prioritize parents' own milk and think about that pasteurized milk, okay, not retorted milk, but that pasteurized milk as a bridge if we did not have enough of parents' own milk available. I also want to leave you with the fact that prioritizing early exclusive breastfeeding, or if the baby's unable to breastfeed, that time-sensitive nature of pumping is so critical, because we do not have an FDA medication approved to treat milk supply, okay? Which means if we don't do step number 2 of my model correctly, which is initiation and maintenance of milk supply, if we don't get people off to the best start with milk supply, we're not going to have long-term lactating families, right? And so when we think about how we message this to families in the prenatal period and the immediate post-birth period, we have to have that sense of urgency about them choosing human milk and breastfeeding, and we have to have that sense of urgency about milk supply, right? So there is going to be a conference this summer in DC in June, which is going to be run by the National Academies of Science as a follow-up to the Congressional Task Force on Research Specific to Pregnant Women and Lactating Women, which I served on for 4 years. I want you to end with this because I want you to understand that it is an exciting time, that we do have some traction in people really trying to think more scientifically about the need for further research to better support lactating families. So as Kim mentioned at the start of our webinar, your certificate will be available on Friday by logging into your account. And I believe I left us with about 7 minutes for questions.
Thank you, Dr. Spatz, for that presentation. I always enjoy listening to your presentations because I always learn so much. We do have a few minutes for questions, and if you would like to submit those via the questions panel, we'll try to get to those. I thought the ads, if you will, on the elevator doors that you showed in your presentation that you saw in Thailand were great, great idea. And your 10-step model always amazes me. Looks like we do have some questions coming in. The first question is, Dr. Spatz, how do you work with the Nicu team when it comes to giving fresh milk to those babies? Our unit, I feel, is always fortified and often frozen.
This is so important because I have seen this in so many NICUs all over the world. When I was working in India, I would see the nurses go in and get pasteurized donor human milk out of the milk bank, and they didn't help families with expressing milk when the family was right there and they could have been feeding fresh milk to the baby. And I think where it really comes down to is helping your NICU staff, all levels of the staff, okay? So whether that be nurses or physicians or dietitians, helping them to understand really the differences in the bioactive components of the milk once we do anything to that milk. Because certainly, as you mentioned, when we fortify, we change some of the components of the milk. When we freeze, we heat treat, all of that. And I don't think ever that anyone ever wants to do a bad job, right? People want to give good care. They want to make a difference. But people really have to understand the why and the science behind it. So that's why I'm a really big fan of helping the parents know that information. Because if the parents know that information, they can drive that feeding of fresh milk, meaning they can come and visit their baby every day, or they can come and visit their baby every other day or every 4 days. And they can say to the nurse, who's really the one who's feeding the milk, here's my fresh milk. I know that my baby needs, 300 mLs the next, 24 hours. So I'm giving you this 300 mLs that I just pumped this afternoon and last evening. And this is the milk that I want you to feed. And so I think empowering our families to understand that fresh milk is important and critical, they can actually help to drive some of the practice change in the unit.
Agreed on that statement. The next question, Dr. Spatz, is, can drinking mother's milk tea during pregnancy help moms to produce more milk after delivery?
That's a great question. And a whole nother topic area, we have a study that we're going to be doing very soon at CHOP about antenatal milk expression. So there's been a growing interest in antenatal milk expression. And so people are thinking about, like, wow, how can I make more milk early on, right? And so, well, that sounds good. Well, let me take some mother's milk tea while I'm pregnant, or some fenugreek while I'm pregnant, then I'm going to make more milk. But here's the thing you have to remember is when you are pregnant, you are in that phase of secretory differentiation, or lactogenesis 1, okay? So you're going to be able to make milk, but you're only ever going to be able to make modest amounts of milk. In order to go from secretory differentiation to secretory activation, you have to have birth of the baby and birth of the placenta, right? So that placenta needs to be birthed so that your hormonal profile changes so that you can effectively come to volume. So while in theory, maybe it sounds good to try to take some milk, or some fenugreek or something while pregnant, it's really that critical window afterwards that we need to focus on to drive milk supply.
Thank you for that. It looks like we have a couple more minutes. I'm going to try to get in as many questions as I can. The next question is, how can we support the mom who really wants to feed at chest and cannot get any measurable milk production?
So, that is a true challenge. And I have worked with families where, they have done everything possible to build their milk supply and they still have a difficult time. For those families, I think it's really important that they understand that any amount of milk is better than no amount of milk. And when I work with families, particularly those who have abnormal breast tissue development or glandular hypoplasia, or families who had breast surgery, I really try to help them reconfigure thinking about their milk more like a medication for the baby, because each drop of their milk has substances that are not going to be available from another source. And then I would have them feed their baby at the chest using a supplemental feeder device or a feeding tube device that parent then could put, you know, donated milk in, or infant shared milk in, or formula in. But it allows them to have the experience of feeding the baby at the chest, you know, and the baby getting whatever the baby can from the breast, and then the additional milk. And there has been some nice research, not a lot, but some nice qualitative research done about with feeding tube devices. It's really about the ability to have the baby at the chest, even if we can't make a complete supply.
Okay, it looks like it's top of the hour. Once again, I thank everyone for joining us today for this webinar. And just a reminder, registration is now open for our May 18th and our June 15th webinars. You can visit medilaeducation.com to find out more about those and to register. And I hope everyone has a great afternoon. Thank you again.